नमो नमः। परम आयुर्वेद आयोजित और पंचकर्म महर्षि वैद्यराज त्र्यंबके पुरस्कार प्राप्त चरक संहिता अध्ययन अध्यापन तद्विद्य संभाषा इस उपक्रम की 316वें पुष्प में वैद्य महेश भुजबल और मैं वैद्य सारिका भुजबल उपस्थित सभी वैद्यों का सहर्ष स्वागत करते हैं। आज के पुष्प के प्रमुख वक्ता आदरणीय गुरुवरिया वैद्य मंजूषा करकरे महोदय जी का भी विशेष स्वागत और आपको सादर प्रणाम। पुष्प का आरंभ हम धन्वंतरी स्तवन से करेंगे।
नमामि धन्वन्तरि मादिदेवम् सुरासुरैर्वन्दितपादपद्मम् लोके जनार्दन भयमृत्युनाशनम् धातारमीशं विविधौषधीनाम् शङ्खं चक्रं जलौकाम् दधतमृतघटम् चारुदोर्भिश्चतुर्भिः सूक्ष्मत्वचातिर्हृद्यां शुकपरिविलसन् मौलिमं भोजनेत्रम् कटितटविलसत् चारुपीताम्बराढ्यम् वन्दे धन्वन्तरिं निखिलगगनमा
धन्यवाद। आदरणीय परम गुरुवरिया वैद्य मंजूषा करकरे महोदया जी का परिचय करने हेतु परम आयुर्वेद के संस्थापक एवं संचालक वैद्य महेश भुजबल जी से मैं अनुरोध करती हूँ।
Namo Namah. Our today's eminent speaker, Dr. Manjusha R. Karkare Madam, is working as a professor and head of Department of Prasuti Tantra evam Sri Rog at Parul Institute of Ayurveda and Research, Parul University, Vadodara, which is a NAC A+ accredited university. She completed her graduation from R.A. Poddar Medical College, Mumbai, and post-graduation in Prasuti Tantra from the prestigious IPGT and RA, Jamnagar. She has guided and is currently guiding several postgraduate and PhD thesis works. She has published several articles in indexed and peer-reviewed journals. She is the principal investigator in a number of sponsored projects. She has worked as a resource person in several online and offline lectures. She was deputed to Israel by the International Academy of Ayurveda to teach Ayurveda and has considerable experience in teaching foreign students. She was awarded the Prasuti Tantra Visheshagya Award by Gujarat Board for Ayurveda and Unani Studies in 2021. She was recently awarded the Kashyap Award for dedication, skill, hard work, patient care, and thoughtfulness in Prasuti Tantra by Nima teachers Param, Gujarat State and Baidyanath. She is also a Reiki Grandmaster and has initiated over 50 seekers into Reiki. She has completed her Jyotish Visharad from Phala Jyotish Abhyas Mandal, Pune. She is a Paira Vastu consultant and uses pyramid remedies for multiple purposes, including healthcare. So I request Manjusha Madam to please present her on anemia in pregnancy. Thank you.
A very good afternoon to everybody. Am I audible?
Yes, ma'am.
Okay. Is the screen visible?
Yes.
Okay. At the very outset, I would like to express my gratitude towards Sarika Madam and Mahesh sir for giving me an opportunity to connect with the audience, connect with our Vaidya Vargas, and share whatever information and knowledge that I have with them. It is indeed an honor to be called as a speaker on this prestigious series, which both of you have been painstakingly conducting over the so many episodes, and the amount of effort and dedication that you have put into this series has truly made it one of the quite outstanding series going on regarding Ayurveda upgradation and updation. Also, I would like to take this chance to appreciate the work that you have been doing regarding the promoting of the Samhita Vachan, which is actually at the root of all the expertise that we need while practicing. The Samhitas are the base, and your efforts must I have definitely helped a lot of Vaidyas to make their base firm, and पाया भरणे ज्याला म्हणतात तो नक्कीच आपल्या एफर्टने झाला असेल. So I would like to take this opportunity, just a minute. So after this brief, so once again, thanking you and appreciating both of you, Sarika madam and yourself, Mahesh sir. I would like to start with today's topic, and that topic which I have chosen today is titled Anemia in Pregnancy. I, being the practitioner of Prasuti Tantra and Stri Roga, I am very much concerned, or why I chose this topic is because it is a major concern in a country like India, and Ayurvedic practitioners can definitely put in their effort and give inputs in this regard, which can definitely help to improve the condition of the woman and pregnant women and ladies in this country. So anemia in pregnancy is my topic for today. And basically, I will be dealing with the iron deficiency anemia. There are many types of anemias which will be now be seeing, but basically, I'll be talking about the anemia related to the iron deficiency in today's session. Uh, okay, so this is the commonest medical disorder in pregnancy. Of all the disorders that occur in pregnancy, anemia is the most common. And if you compare the rate of anemia in the developing countries versus our countries, you can see it is a staggering 40 to 75% of pregnant women are anemic in the developing countries. Whereas compared with the developed countries where it is only 18 to 20%. So we see the drastic difference or the drastic condition that the women in the developing countries are facing. Why is anemia so important? What exactly is anemia? Anemia is basically where the red blood cells, which we all know carry the oxygen to the cells. These cells, anemia in these cells, the red blood cells, their oxygen carrying capacity is insufficient. It cannot meet the physiological needs of the individual, and that may vary. This need varies from age to age, sex, attitude, the smoking status, the pregnancy state, the age of the person, and the overall fitness of the person. All that make a difference. What is the physiological need of that person? And that is not met by the current status of the uh, patient's RBCs. And this condition is termed as anemia. In pregnancy, if you go to see, if the HB levels are less than 11 gram per deciliter or 10 grams even, then it is considered to be an anemia of pregnancy. What is happening exactly? How are the RBCs being formed? In the RBCs in adults are found basically in the bone marrow, and they go through a number of stages like the pronormoblast, normoblast, reticulocytes, and then they mature into the non-nucleated erythrocytes. We have all learned that the lifespan of the HB hemoglobin is 120 days, which is why we do a glycated hemoglobin in diabetes. It is related with this hemoglobin, and it gives you a picture of the 3 months of the patient's sugar control. So 120 day is the lifespan of these RBCs, and they are broken down into hemosiderin and bile pigment. After the breakdown, they are released. Hemosiderin and bile pigments are released. If you go to see normally in females, the RBCs are about 4.5 to 5 million per cubic millimeter, and this um, HB should be around 12 to 14 gram per 100 cc of blood. So that is in the general condition, whereas in pregnancy, we desire that it should be about 10 to 12 grams at least. Anything below 10 is a alarm sign for the obstetrician. So doing the HB at the first visit itself is the main thing that you can do to catch these people early, catch them early, treat them early. So during pregnancy, the woman needs extra iron, extra iron. How much is required? 1500 milligrams. So that is not much actually. 1.5 grams, 1.5 gram iron, kuch badi baat nahi hai. But getting that into the system is a big thing. Where do we need all this iron? So basically, the mother's HB has to rise because her blood has to supply to the fetus, to herself. Her body's needs are increased. So even her requirements of oxygen are increased. The fetal requirements are increased. So her HB has to increase. So there the iron goes. Then a lot of iron is used in the fetus and the placenta. Some iron is lost by daily as a metabolic byproduct, and metabolically it is lost through the urine, stools, and the skin. And most importantly, at delivery, after the delivery of the placenta, 200 milligrams of iron is almost lost. Thereafter, even during lactation period, the mother needs the daily 1 milligram per day. So all these are the places, all these are the things why iron is required in the pregnancy. Now, there is something called as the physiological anemia of pregnancy. What is this physiological anemia? It is a part and parcel of pregnancy. What is happening is that the plasma volume in pregnancy is expanding by 50%. So if a normal woman has approximately 5 liters of blood, she will be having more 2.5 liters of fluid running in her body. Rasa dhatu is increasing. Rasa dhatu is increasing. Why? Because the fetus is surviving on the bala of the rasa dhatu. So the rasa dhatu increases and the volume increases. Now, by how much is it increasing? Almost 50% of the original. But what is happening? That the RBCs in the blood are increasing by only 25%. So apparently, what is happening? Apparently, the volume is so much and the RBCs are growing in lesser quantity. As a result of this, discrepancy between the plasma volume and the RBC volume, it appears as though the patient is anemic. And this condition is called as the physiological anemia of pregnancy. It is occurring in every patient, in every pregnant woman. Now, what is happening during pregnancy is that the RBC mass is increasing to meet the demands of the mother and the fetus. And this is all for completing the demand of the mother. And this demand, almost like I said, 1.5 milligram of 1.5 grams, that is 1500 milligrams are required in the total pregnancy. And basically this requirement increases in the second trimester onwards. In pregnancy, this estrogen causes an increase in the erythropoietin secretion from the kidneys, which stimulates erythropoiesis. So naturally, the pregnancy hormones are trying to promote the growth of the RBCs. This is happening during the normal pregnancy. In pregnancy, also, generally, in what is happening is that the iron has to be converted from ferric to ferrous, and the protein called as the ferroportin, it transfers this ferrous iron across the duodenum across the gut into the bloodstream, where the protein called as the transferrin takes over and transports it to the liver and the marrow. Now, what is liver doing? So liver is storing this iron, and it also controls the uptake of the iron. How does it control? By releasing an enzyme called as the hormone called as the hepcidin, and this hepcidin causes degradation of ferroportin. So once the ferroportin receptors are degraded, they are down, there is no more absorption of the iron. But in pregnancy, what is happening? Body naturally inhibits the hepcidin, and as a result of that, maximum iron is taken into the mother's system, and pregnancy itself promotes this iron absorption by RBC generation by means of these several hormones that we just saw. Another important work that the ferroportin does is that it transports the iron across the placental barrier. So taking it across to the fetus is also an important work that the ferroportin does. Now, like I said earlier, this plasma volume increases by 40 to 50%, RBC mass increases by 20 to 30%, and hemodilution causes the physiological anemia of pregnancy. So pregnancy is therefore mimicking an iron deficient state. So all these are the values that you are going to get to see in a pregnancy report if you do the total blood report of the patient, then the total iron binding capacity is seen to rise. Why? Because the more and more iron is needed, and the binding capacity therefore increases. Like I said, the physiological anemia, which we earlier saw, why is it happening? Why is nature creating this physiological anemia? So as we know, how is the Garbha Poshan happening? Garbha Poshan is happening because of the mother's rasa dhatu. So rasa has to flow throughout the body, across the placental barrier, and then only the fetus will be nourished. So if we see the Vimshati Gunas, then we can appreciate that if the Dravatva of the rasa rakta dhatu increase, then only that Tarpana Kriya of the Poshan Kriya of the Garbha and the mother, the transfusion or the perfusion across the placenta is going to improve. And that is also one of the reasons why during the first 3 months, and throughout the pregnancy also, more stress has been laid upon the Drava Prayahar. Visheshatah to Prathama Dvitiya Tritiya Mase Madhura Shita Drava Prayamaharam Upaseveta. So Dravata is the Vimshati Gunas, how you are applying. So the Vimshati Gunas, the Dravatva of the Rasadhatu has to increase, and therefore nature itself is increasing the volume of the plasma and reducing the viscosity of the blood. If there are too many RBCs, it will be too viscous, it will be ghana, and the Dravatva will not be there, and its perfusion will not be adequate. Now, what is happening because of that? If the mother is also hypertrophied, so entire thing has to be perfused nicely. Second thing, the benefit of it is that if the volume is expanding, then it also protects the mother and the fetus. From what? Now the weight of the gravid uterus is all coming onto the big vessels if they are in the abdomen. So this weight of the gravid uterus, especially in the supine position and the erect position, is likely to cut down the venous return, and that can result in hypotension. It can reduce the volume of the blood reaching the heart and consequently reduce the blood being perfused to the fetus and the mother in return. So, if the volume is expanded, the mother and the child get saved from this effect of the hypotension. Another very important thing that this plasma dilution helps is that the number of RBCs lost, the number of RBCs lost if the patient happens, let us consider that the patient is having a normal delivery and the placenta is coming out. We all know that during the loss of removal of the placenta, blood is lost during that process. So in such cases, or blood loss can occur even if in abnormal cases where the patient may have antepartum hemorrhage or postpartum hemorrhage also. So when such normal or abnormal blood loss has to be faced by the patient, then in such conditions, this diluted blood ensures that the woman does not lose a lot of RBCs. She will lose plasma, but the comparatively she will lose lesser number of RBCs, and that will help to save her life. If the blood was thicker, if there was more viscous, if there are more RBCs, then 1 liter of blood loss would have resulted in a loss of lot of many more RBCs than a diluted blood loss would lead to. So this is the nature's way of protecting the mother by causing the physiological anemia or the hemodilation. So it creates a picture. Multiple pregnancy. Now, iron metabolism, if you go to see, then in pregnancy, what we are concerned about is that the normal pregnancy, and along with that, other if complications occur during a pregnancy, then anemia is likely to increase the morbidity of that patient. Why do you want that the patient should have a better condition? Because multiple pregnancy, antepartum hemorrhage, preeclampsia, postpartum hemorrhage, they all are some of the very dangerous complications that may occur in the during a pregnancy and childbirth. And anemia adds to the morbidity of this condition. So, for example, if a mother is a normal mother having a good HB, then she is likely to have lesser morbidity as compared to a woman who is, if she's already anemic and she goes has preeclampsia or she has antepartum hemorrhage, then her morbidity is likely to increase not only as a result of the comorbid condition like preeclampsia or APH, but anemia is going to add to her morbidity. So prevention is the key word, and for that we need to improve the socio-economic status factors of the adolescent girls, educate the small children, small girls, adolescent girls, teenage girls about the rich diet. Try to give them supplements before they reach the reproductive age and help them to build up their iron stores before they plan a pregnancy or they enter a pregnancy. And of course, adequate supplementation during the pregnancy is also essential. The total iron requirement is around 1000 to 1500 milligrams in the total pregnancy. We also know what is the average requirement per day. It is 4 to 6 milligrams per day. But in the early pregnancy, it is just 2.5 milligram, whereas the maximum requirement is 5.5 milligram in about 20 to 32 weeks. So we can see that major requirement starts after the 16th week of pregnancy. After the 16th week of pregnancy, the major supplementation is required. We can advise the patients for these iron-rich foods I will talk more about this when we come to पथ्य इन पांडु का पथ्य बताते समय भी आचार्यों ने बहुत अच्छी तरह से हमें उसके ऊपर पथ्य अच्छे बताए हैं, वो भी हम देखेंगे. So from second trimester onwards, diet is unable to provide the required iron supplements. So we need to give them the support in form of medicines, because diet alone cannot make up for this increased demand. Now, according to the modern sciences, their ferrous sulfate and all those supplements that they give, they are more likely to cause aggravated symptoms. Aggravate the symptoms of vomiting, nausea, and GI tract upsets in pregnancy. So generally in modern medicine, it is started, supplementation is started 16-week onwards. How do we classify it? Something 9 to 10.9 gram is classified as mild. 7.8 to 9 grams is classified as moderate. Less than 7 is severe, and less than 4 gram is very severe. So doing the HB at the first visit itself is the very important thing that a person should do while treating the pregnant woman. Physiological anemia, pathological anemia, the main type is the iron deficiency, folic acid deficiency, vitamin B12 deficiencies. And then you have the hemorrhagic anemias, in which which may be acute because of some bleeding, or it may be chronic also due to the worm infestation or bleeding piles or epistaxis, like things which we have to be careful to elicit from the patient while taking the history. Hemolytic anemia because of congenital jaundice, sickle cell anemia, all these thalassemia, these are the other anemias which are associated with Hello.
Yes, ma'am.
I will continue. Can I continue?
Yes.
Slides are visible.
आवाज येतोय.
Hello.
येतोय मॅडम आवाज.
हा येतोय मॅडम आवाज.
Okay. I should continue, no?
हो हो.
Yeah. So how does this patient present to us? Now the patient main symptom that we get to see is that easy fatigability. Patient gets complaints of tiredness, feeling of weakness. They may have headache, dyspnea may be there, breathlessness, shortness of breath, and the patient may also experience palpitation. You can also get to see giddiness, swelling of the legs may be present. Patient's appetite will be less. So even the Agni Mandya, it is expressed in this condition. Loss of hair fall, jada jayega, or all these symptoms the patient will be presenting with us. What can you see in the patient when you see? There will be the pallor, Pandustu Pita Bhagarda, the yellowish discoloration of the skin. You cannot call it discoloration, it is a kind of pallor, but there is a Vaivarnya kind of thing. Varna में वो व्यक्त हो जाता है. And it is on the detected on the face, palm of the hand, nail bed, mucous membranes of the mouth and the conjunctiva. Patient may also have angular stomatitis, and the nails may be brittle, and uh, their luster will be lost. So we can see this in the normal patient with a normal blood count, RBC count. See the you can appreciate the difference of the color. A robust red colored expression of the blood versus the hand on the left side, which is totally pale. So this can be appreciated drastically in the sites that I mentioned. Dyspnea on exertion will be there. Lethargy will be there. That also will be there. And mood will be also not good. It even affects the patient's cognitive abilities. So all these things, they may be seen in the patient. If the patient is having any history of change color of stools, like the blackish melena, if it is present, then you need to look out for the any GI tract bleed also. And very severe anemia may result in the patient having the failure, cardiac failure, or even angina can happen. Spleen enlargement can also be seen in these patients. What are the causes of this malady? So reduced intake or absorption, excess demand, and blood loss. These are the main causes of this iron deficiency anemia. So many times it is the deficient diet, or it is the impaired grahani and impaired digestion and absorption which results in this anemia. Almost 95% of the anemic pregnant women are known to be having iron deficiency anemia. So it is just 5% of the remaining things that we saw, the hemoglobinopathies and other reasons, they contribute to just 5% of the anemia in the pregnant woman. 95% of them are known to be because of iron deficiency only. Then how does it affect the mother and the fetus? What is the effect on the pregnancy? So it reduces her immunity. Because of the oxygen carrying capacity is reduced, the tissue vitality or the pran of the tissue is reduced, and that makes her more susceptible to catch infections. She is also not able to withstand any accidents that may occur, accidents in the form of antepartum hemorrhage or postpartum hemorrhage, it may she is more likely to have a morbid outcome. Then even in uncomplicated labor, the heart is not able to take up this pressure of the labor, demand of the labor, and during labor she may have a cardiac failure. These women are also known to be more prone for pregnancy-induced hypertension and preterm labor. If she goes in preterm labor, it is a very sad situation for the baby, because the amount of nourishment it should have received earlier, it does not receive, and it is uh, coming into the world without getting fully formed or without having the adequate support and adequate system bulk of the systems that it should be having. So prematurity is one real danger, because because of the anemia and the poor nutritional status, the membranes are becoming more friable, and they may also have preterm rupture of membranes, premature preterm rupture of membranes also. And all this results in the potential threat to her life and deprives her of the joy of being pregnant or enjoying her pregnancy. She is likely to have poor weight gain, go into preterm labor, and may be predisposed to placenta previa and premature rupture of membranes also. During the intranatal period or during the labor, the dysfunctional labor increases in such women, and also she may have hemorrhage, shock, cardiac failure. And if at all we need to do a cesarean section, the risk for anesthesia is also greater in anemic women. During the postnatal period, there is subinvolution. The uterus does not involute normally because the bulk of the mansa is also reduced in such cases. Because of her low immunity, she's likely to have postnatal sepsis, and the chances for embolism are also higher in such women. How does the baby suffer? The baby has lesser oxygen to its share. It is not getting the required oxygen. It is not getting adequate oxygenation, and that compromises its growth and results in growth retardation. Prematurity is another threat. Because of preterm labor, the baby is born premature and has to struggle to catch up with the growth. Low birth weight may also take place because of growth retardation. The low birth weight babies may also be coming to life, and even low birth weight is known to be a potential source of adult diseases. So, diseases like diabetes and hypertension are now known to be originating right from the mother's womb, because at the fetal life there is insult that results in that particular baby growing up to have more risk of the metabolic syndrome, hypertension. So fetal origin of adult disease, if we look at them, then this danger for the future life of the baby also we should consider, and we do not want that insult to happen. We do not want a preterm baby. We do not want a low birth weight baby. So optimizing this status of the mother is the only thing that we can do for such avoid such risks. And increased risk of perinatal morbidity and mortality is also there for such babies. Now, if such patient comes to us, what are we going to do? We are going to take her proper history and search for any sources of bleeding if she is having. First, take them out. Ask for the passage of worms in the stools. Ask if she is losing blood from anywhere, in urine, from the rectum as a result of piles, or maybe from the nose, epistaxis. Ask for her history if she has been taking proper iron and folic acid in this pregnancy. Ask for the if she has heavy menstrual period. Try to arrive at the cause of the anemia, whether it is just nutrition deficiency or whether it is there is any other blood loss causing agent also involved. So this should be ruled out. Ask her for any history of bruising easily. See how her period between the two pregnancies is. If the mother does not have a good amount of period between her pregnancies, she is not able to replenish her iron stores before entering the next pregnancy. So one pregnancy and immediately second pregnancy after within a year, then the patient is likely to have these poor iron stores in her blood, in her body. Ask for family history of hemoglobinopathies and whether she had any blood transfusion is required. What is the diet that she is currently taking? That also we should be knowing. Examine the patient for the pallor at the sites that we mentioned, mucosa, skin, all these places. See whether the patient has this chiliosis, koilonychia, tachycardia, edema, and if required, we can also do the later on we are also going to take up the iron workup. These hemic murmur or the ejection systolic murmur may be also audible in the mitral area on the auscultation. Why we want to investigate? We want to know the severity of the anemia, type of the anemia, assessment of the iron stores. So for all this, we are doing the investigations, and we need to know along with the other investigations of the ANC like HIV, hepatitis B, VDRL, urine. We have to know the iron, HB, RBC indices like the mean corpuscular hemoglobin, mean corpuscular volume, mean corpuscular hemoglobin concentration, RBC density width, and the peripheral blood smear will help us also differentiate the types of the anemias, and HPLC may be needed for diagnosing hemoglobinopathies and hemoglobin variants. So at the very first ANC visit, which whenever she is coming to us, HB is a must. Apart from the group and other things, HB has to be done, and other blood indices, RBC indices, and the things that I mentioned in the earlier slide, they have to be done. So what do we see generally? We see that the serum ferritin serum iron, serum ferritin, they are all falling, and total iron binding capacity is increased because the blood wants to catch more iron from the diet. Okay, then the mean corpuscular hemoglobin is also falling in these cases. In the normal person, the RBCs hematocrit has to be 42% at least. So this blood standard needs to be checked when the patient comes to you. Now we see what is the mean corpuscular volume. It is a measure of the average volume of a single blood red RBCs. So this count and the MCHC and MCHC and MCH, all these give an indication about the severity of the anemia of that patient. So in detail, we need to study about these values. The ratio of the volume of the red blood cells to the total volume of blood, that is the hematocrit. Now normal hematocrit for men it is from 41 to 50%, and for women it is 36 to 48%. So low hematocrit is an indicator of anemia, and it can occur in pregnancy and also in other conditions where there may be bleeding or any other problems like the sickle cell or bone marrow suppression or cancer. They also may present with the low hematocrit. This is just for the information of where other places you may find the low hematocrit. But in pregnancy related anemia, this low hematocrit may be found. So here is the picture of how the hematocrit differs, how the blood picture differs. Now this, you can see in the test tubes that the normal blood is obviously having the more RBCs and the hematocrit is good. It is around 37 to 47%. Whereas in anemia, the hematocrit is decreased, the RBCs are decreased. Serum iron levels, they also help us to find out the severity of the anemia in the patient. Generally in adult women, 38.3 to 48.6%, 35.5 to 44.9% is the range for the serum iron levels. So this again is the picture how the iron is collected from the duodenal tract and then transferred to the liver, and the how the ferroportin and the transfer in these proteins play an important role in making this transport to and from into
आवाज
the
नाही येत मॅडम.
hello hello hello.
Continue, madam.
Okay, is there any disturbance or loss of contact?
No, I'll mute him.
Okay. So transferrin, what is transferrin? Is a protein in the blood that transports the iron throughout the body, and total iron binding capacity measures how well the transferrin proteins are transporting iron around the body. So all these levels, they are done to get the clear picture of the patient's uh, patient's blood picture. Even the ferritin test, what does the ferritin test tell you? Ferritin is the protein which stores the iron and releases the iron when the body needs it. So serum ferritin level tells us the iron source. Low ferritin reflects low iron levels in the iron storages in the woman's body. All these tests are done to find out the severity. Then the total iron binding capacity is normally ranges from 240 to 450 micrograms per deciliter. And a very high TIBC indicates low levels of iron, which is why the body is trying to compensate. On investigation, what are we going to see in these patients, anemic patients, that the MCV or the mean corpuscular volume is reducing, and all the MCH is reducing, MCHC is reducing, RBC density width is increased. Now this width will increase because of the difference in the sizes of the patient's RBCs. So more the difference, more is the RBC density width, and it is an indicator of the raised RBC density width is an indicator of the anemia or the iron deficiency in pregnancy. RBC cell smear will show poikilocytosis and anisocytosis, that is different sizes and different shapes of the RBCs. Then the pencil cells, teardrop cells, we will take a look at the smears, how they look in these patients. I think it's further down. Further down in later in the some of the later slides, I think the smear will come. So all these things, they can be diagnosed on the peripheral smear, and in the lab work, this will be seen. So serum ferritin lesser than 15, transferrin saturation less than 15, all these things, they indicate the anemia of the patients, and these are the things that we can investigations we can do to confirm the diagnosis. If there is folic acid or B12 deficiency, then on the smear we'll see the macrocytic anemia. A macrocytic is the large cells that will be present, whereas in the iron deficiency there will be the microcytic and microcytic anemia, or the hypochromic and microcytic. The size and the pigment, both in the RBCs are getting reduced. But the smear picture on folic acid and B12 deficiency will be different. So this smear will help us to differentiate the nature of the anemia, or the exact pinpoint the cause of the anemia. Now, what are this? What are the measures that we can take? So there are the dietary measures. We have to focus on deworming, iron supplementation, and if required, the blood transfusion are indicated in this anemia in pregnancy. Iron-rich foods. We all know about what iron-rich foods are to be taken. The jaggery which we are currently getting, it may be the chemical jaggery which does not contain that iron, but the original blackish colored good, or the black jaggery, which we still get, that is more indicated, I would say, for the getting the iron supplement. Because the bright yellow colored jaggery, it was treated with chemicals to make it look bright and attractive, but the iron stores, or it is definitely not very advisable for the pregnant woman. and the jaggery which is blackish colored, not treated by bleaching agents, should be advocated. Of course, we all know about the green leafy vegetables are advised by the modern sciences. Ayurveda practitioners differ in their opinion, saying that the leafy vegetables, though they may be containing iron and all these micronutrients, they are more prone to generate the mala and not the dhatus. And therefore, we are giving more focus on the phala shaka kind of shaka varga and not the leafy vegetables. But apart from that, you can also ask them. I will talk about the other diet things that Ayurveda can contribute, and what we can ask them to do is that cook in the iron utensils. Now slowly it is steadily coming back, using iron utensils, using the clay tawas and clay pots for cooking is slowly coming into vogue once again, maybe as a result of the sophisticated way in which those items are presented. So it is, you can take the benefit of that and promote the use of this iron and clay utensils in these people. What we need to tell this patient is not to take the iron supplement, whatever they are taking, whether it is the Ayurvedic combination or ferrous sulfate, is that it should not be taken with the tea or coffee, because then the absorption is going to be impaired. If we add ascorbic acid or vitamin C in the form of lemon or amalki, then the iron metabolism improves and results in a better hemoglobin supplementation. It if the patient takes it in between meals, it will prevent the GI tract upsets, and we can also ask them not to take it on an empty stomach. Also, the iron and calcium supplement. Calcium is also advised in pregnancy. It is important that these all, the patient doesn't gulp them down all at the same time, because taking iron and calcium together is going to impair the absorption, and they should be taken separately. Calcium can be given on empty stomach, but iron should be taken in between the meals. Or in the modern world, if the patient has access, they can use the fortified foods, pulses, cereals, jaggery, beetroot, vegetables, and those who are eating the non-veg can be asked to consume egg, fish, all these things they can consume. How much is required? How much of iron is required? Elemental iron 30 to 60 milligram and folic acid 400 microgram is required for the pregnant woman to prevent the sepsis, low birth and preterm weight of the preterm outcome of the pregnancy. Then we have seen this earlier. Cardiac failure can occur if it is not treated. Preterm labor can occur, preeclampsia. All these are the complications that can occur as a result of anemia not being treated. Then in puerperium also the cardiac failure can occur. Lactation problem can also be there. We didn't talk about this earlier. Even failing lactation may be a result of poor nutrition and anemia also. And if the, of course, who is not if the proper postpartum care is also not taken, Garbhini Paricharya is also not done, Sutika Paricharya is also not done, then this is going to snowball into giving a chronic ill health to that woman, and she will also this over the years her jara avastha is going to arrive early, and other problems she is going to face over the as she approaches her menopause and the praudhavastha and jara avastha. This neglect is going to have its effect more predominantly felt at that time. So that is why this Garbhini Paricharya, handling this anemia and nutritional deficiencies in pregnancy and taking care in the Sutika Avastha is also so much essential. Then the fetus, like we said, prematurity, growth retardation, and there may be also perinatal death of the baby because of the poor health condition. Of course, the baby does not get born with anemia because the baby sucks in all the iron that the mother has to offer. But later on in life, after 6 months, it may have reduced iron stores, and as a result of that, the young one will have the anemia. So at newborn, neonate will not suffer from the anemia, but later on the young child is likely to suffer. Now, the oral iron therapy is the safest and most inexpensive way. Suggested, this is the supplement is the 60 milligrams of elemental iron and 500 micrograms of folic acid daily. But if that is for the prophylaxis, every woman, irrespective of whether she's anemic or not in pregnancy, is suggested to take this dose 60 milligrams of elemental iron and 500 micrograms of folic acid. But an anemic woman needs more supplement, and 120 milligram of elemental iron and 1 milligram of folic acid is the dose recommended for these women who are anemic in the pregnancy. So this is the government of India sachet or the supplement that we are getting, and it is giving for first half 2 to 3 milligram per day, second half 6 to 7 milligram per day. That is the iron supplement that is being given. That is the iron that is made available to that woman through the government supply. Now, so many things, combinations of iron are there available. Ferrous sulfate, fumarate, like gluconate, succinate. Lot of options are available in the market, and we have to see what the patient is not tolerating well, because these combinations are known to cause GI tract upsets. What is needed is that taken between meals, start with a low dose and then to decrease the side effects. And if they are not tolerating, the brand may be changed. Then what are the common side effects? Are that the upper GI tract, she may present with nausea, gastric discomfort, loss of appetite, and the staining of the teeth was also one side effect of this oral iron therapy. And some patient may have this lower GI tract problems related to constipation, diarrhea, flatulence. All these things, they make the metallic taste in the mouth, which is very, very irritating for that woman, that makes her to discontinue the iron therapy. So they will take the tablets home, the government supply, they will take it home, but they will not be eating it. And then also there are, as per the person, there are variable absorption rates are also there. So one person having the different people, women may have different benefits from different level of benefit from that same supplement. After giving that patient, we have to check the HB again after 4 weeks, whether it is increasing or not. After 4 weeks, if it is not increasing, you have to take a second look at something going wrong. And of course, we have to check with the compliance, whether she's taking it home and eating it or not eating it. So that is one thing, because of all these problems that we saw earlier, metallic taste and diarrhea and all that, the patient may not be also taking the thing properly. So repeatedly ask them. One of the trick questions that you can ask them is, what is the color of your stools? And if they are actually taking the iron supplements, their color is likely to be black. So if they are saying that the stools are black, then definitely they are taking the iron supplements, and ask them to show the empty packets. So all these things you can tell the patient and try to check for the compliance. When is the para-enteral therapy advocated? When do we want to give it to her? Because if it is not going to increase the iron faster, that is the myth that we believe. If we think that it will increase it faster, it is not so. Intramuscular iron therapy injectable is going to increase the HB levels at the same rate. Only benefit is that the compliance is ensured. That is the benefit of the parenteral therapy. You give the injection in front and it is going into her body, whereas the tablets, you are never sure whether the patient is taking. So if they are intolerant to oral iron, if you are suspecting that non-compliance, then the iron therapy, parenteral intramuscular injections can be advised. In advanced pregnancy, and if there is severe anemia, then also we can take the decision for giving the intramuscular. We are going to avoid these intramuscular therapies in times of hemoglobinopathies because there is already iron overload is already there. So the loading with the iron is not required in such cases. If there is a hypersensitivity reaction, then in the first trimester, active infection and in the presence of hepatic dysfunction, we cannot give these injectable ions. Then, before starting the para-enteral iron therapy, we have to confirm the diagnosis of iron deficiency. That confirm that we are not overloading the already loaded patient with iron. Confirm that it is iron deficiency. By this can be done by the serum iron studies. Serum ferritin is reduced, TIBC is increased, and serum transferrin receptors are increased. All these things they will help us to confirm the iron deficiency, and then only we can start loading the para-enterally the iron thing. Hemoglobinopathies has to be ruled out by doing the HPLC, and sickle cell thalassemia, they will actually not benefit, but they will have a problem if the iron is overloaded. B12 and folic deficiencies, again by using the smear we have to rule out. We have to stop the oral iron before starting that parenteral iron, so to reduce the risk of reactions. There are two things are there in the market right now. They are the iron sucrose and the FCM. They have to be administered under the supervision strictly. You cannot just put her on the drip and then leave her. They have to be monitored and kept a watch over, and watch for the reactions like the chest pain, rigor, chills, or even the anaphylaxis. So all these therapies they come with a risk, and we should be alert about this if the thing we are planning to use those therapies. How much iron does the patient need? How do you calculate that? So there is a formula for the calculating the amount of iron that the patient needs, and according to the body weight, 2.4 into the pre-pregnancy body weight, the target HB which we count at 14 minus the actual HB plus 1000, that is the amount of iron that we want to give to the patient, that for increasing her HB to the desirable levels, and that has to be accomplished through this therapy. Parenterally, the iron dextran injections were used earlier, and some people, old timers, may still be using. They have a that injection is little painful, and they have carry a risk for the anaphylaxis also. But when I was resident in Podar, this was a common thing that we are using in combination with Vitcofol also. Alternately on each buttock, that was the combination that we were giving for the patient. So iron dextran is one thing, and the technique of giving this is the Z technique, which ensures that the iron does not leak back to the skin and cause the discoloration of the skin. So this technique is the way, the intramuscular Z technique is the way it is advised to be given. The other injection that we have in the intravenous iron therapy are the iron sucrose and the FC, ferric carboxymaltose, FCM, that we saw earlier. These are the two options that are available in the intravenous. The benefit of ferric carboxymaltose, it is more costly. Actually, it is more costly than the iron sucrose, but the benefit is that you can administer more iron. That's almost 1000 milligrams in 200 ml can be given in a sitting, one sitting, whereas the iron sucrose only 200 milligram can be given at a stroke, and a repeated dosage is required, whereas more iron can be delivered through this newer formation. Of course, the cost is more, and patient affordability needs to be seen. Then assessing the response to the iron therapy. So symptoms have to be improved. You have to assess it after 2 weeks, see how the appetite is increasing, see the pallor, HB 6 to 8, after repeat the HB after 4 weeks. And if there is no improvement seen in the patient after 3 to 4 weeks, then we need to reevaluate and consider if there is any other cause or we are missing out on something. This is another one of the Jectofer is another one of the intramuscular injectables that we have using. Intravenous iron sucrose, IMAX, it is given free in the government of India supply. Whereas ferric carboxymaltose, these need to be purchased by the patient, and patient may not be able to afford it. The complications that are known to occur with this are the local thrombophlebitis at the IV site, systemic malaise, and urticaria. These are may be seen, and we have to need to handle these complications appropriately. When do you need to give BT to this pregnant patient? So, and whenever severe anemia, when is severe anemia? Less than 7 grams. If it is less than 7 grams at any gestational age, the BT is indicated. If the patient is at 36 weeks or more and HB is less than 6 grams, then also we need to give immediately the blood transfusion. If it is within 6 to 8 grams, but the patient is presenting with symptoms of cardiac failure or hypoxia, if there are other problems associated with it, like the malaria or pre-existing heart diseases there, then also this BT is indicated in the pregnant patients, irrespective of their gestational age. Iron therapy patient is failing to respond, and of course in emergency conditions like APH, PPH, or rupture of the uterus, first trimester hemorrhage, these are the conditions when the BT may be required. Patient coming to you in labor with HB less than 7 gram, that also is an indication for the blood transfusion. Adverse reactions, we have to be aware of them, and close monitoring during the BT is essential. Transfusion reaction, volume overload, all these are the associated problems that may take place with the BT. So during labor, what we need to be aware about is that the first stage, we have to give her the comfortable position. Adequate analgesia is required. If she is not able to tolerate the pain because of her poor status, the analgesia may be needed in the form of epidural, and oxygen support must be available. Continuous oxygenation by the mask, if it is given to the patient, it will help her to tolerate it better. Then antibiotic prophylaxis may be needed because of the poor nutritional status. These women are prone for the postnatal sepsis. So you may want to start her on the prophylactic antibiotics. In the first stage, we need to give her the propped up position, oxygen by the mask. We have to ensure that there is one bag of blood cross-matched and kept ready if she at all she requires. Aseptic precautions have to be very strict. Why? Because, of course, to prevent the sepsis to the mother and to the child. Antibiotic profile, watch for the signs of pulmonary edema, cardiac failure, and restrict the IV fluids also. Not too much of IV fluids to be given to these patients. Then in the second stage, we can try to cut it short by the use of assistance in the form of vacuum or forceps, and strict asepsis also has to be followed in this stage. Then in the third stage, actively manage it by using the uterotonics like methergine has to be given so that the blood loss is minimized, and delayed cord clamping and controlled cord traction. All these things we need to do for the benefit of the patient. During puerperium, adequate rest is essential. Iron supplement again should be carried out 60 milligram elemental iron plus 500 milligram of micrograms of folic acid, 6 months, and keep a watch for this failing lactation, subinvolution of the uterus. She should be advised contraception. So the second conception should not come immediately on the back of the finishing first conception. If she's going to conceive again immediately within few months, again the same story is going to repeated, and the coming praja is going to get more and more weaker, and the mother is also going to get more and more weaker. So this is the general thing that we need to know about managing the anemia in pregnancy and during labor. Now coming to what can we as Ayurvedic physicians do for this malady? So is there anything that we can contribute? So I tried to compile the few references of Garbhini related Pandu, and we are all Vaidyas and we know that certain maladies in pregnant state, we have to build up our chikitsa on the basis of the general disease that we study in Kaya Chikitsa itself, and apply the same principles to the pregnant woman. Always remembering what we need to consider in the pregnancy state is that the excessively tikshna, ushna upacharas, excessively drastic methods of management or drastic drugs, tikshna, ushna drugs should not be used in the pregnant condition. That is the baseline rule that we should all remember while treating the pregnancy maladies. Anything that is related with the pregnancy or pregnant woman, it has to be treated with saumya aushadhis and saumya upachar only. Shara, Agni Karma, again they are contraindicated in the pregnant state. So Pandutvena upalakshito rogaha iti Pandurogaha, where is the Panduta or the pallor is the predominant symptom presenting there. So the Pandu name is given to this Vyadhi. And in Harita Samhita, there is a Garbha Upadrava have been mentioned, Ashtav Garbhasya Upadravaha. There we come across this word of the Vivarnatvam, which can be compared with the Panduta. Panduta again is the pale color of the skin that is the main symptom of this disease. And that is why this Vivarnatva, which is mentioned as one of the Garbhopadravahas, Garbhasya Upadravaha in Harita Samhita, can be taken to be the reference for the Pandu as per the Ayurvedic classics. There is a Kashyapa Samhita in one of the in Khilastan also mentions a cause of the Garbhini Pandu. It is very interesting to note that he has mentioned the pressure of the growing uterus and the garbha upon the nabhi. As we all know that the nabhi, rasavaha nabhi are starting from the rasavaha srotas nadis are starting from the nabhi pradesha. Sarva rasavaha nadyaha samantan nabhimashritaha. Garbho vivardhamanasya sampideti tastriyaha. So the growing garbha pressing upon the nabhi also causes the pressure upon the rasavaha nadis that are present on the nabhi, and in the same way raktagulma also causes that pida to that woman. Tabhishya pidya manabhir na samyak vartate rasaha. Because of this pressure on the rasavaha nadis which are present at the nabhi sthan, the rasa suffers, the quality of the rasa suffers. No samyak vartate rasa. The rasa does not circulate properly, the rasa is not formed properly, and as a result, apandu gandatadini lakshanani bhavanti ataha. So the ganda and other organs, ganda is the cheeks and other organs, they apandu gandatadini lakshanani bhavanti ataha. They create the lakshan of the pallor in that patient. That is the way Kashyap has described this Panduta, the cause of the Pandu in the Garbhini. So very interesting to note that this hemodilution is also occurring at reaching its peak at the time of 32 weeks, and the pressure of the garbha on the nabhi is also occurring at around at the same time. So the correlation can be seen between these two uh, schools of thought. Sushruta Samhita again tells us that Vyayama, Amla, Lavana, Madhyam, we all know about it. Excessive use of the Amla and Lavana rasas, use of Madhya, Divaswap, or very Tikshna foods and drugs, they cause the Dushti of the Rakta and cause the Pandu Roga. Ashtang Hridaya also mentions Garbha Vruddhi, Prasavaruk Kledats, Kleda, Asrasruti Pidanaihi as to be the sum of the few causes of Pandu. So Garbha Vruddhi and Prasavaruk, all these are contributing factors to the Pandu, creation of Pandu. Pandu, according to Ayurveda, is considered to be a Pitta Dosha Pradhana Vyadhi. Dosha Pitta Pradhana Astu Yasya Kupyanti Dhatushu. So there is because of this Pitta, there is excessive Pitta, and this Rasa Dushti, Shaithilya शैथिल्य आ जाता है, धातुओं में शैथिल्य आ जाता है, उनका बल कम हो जाता है, और इससे क्या होने वाला है कि वर्ण, बल, स्नेह, ये सब ओज के गुण हैं, वो उनकी व्यक्ति हमें कम होते जाते हुए दिखाई देती है. वर्ण में भी ये चेंज आ जाता है. बल, reducing bala, causing the easy fatigability, easily weakness, getting the weakness, and sneha becoming less, resulting in the loss of tone of the muscles, or sneha becoming less also contributes to the excessive rukshata. Lack of sneha causes rukshata in that pregnant woman, and this rukshata is expressed not only in the skin of that patient, but this rukshata, it is expressed in the skin, but from seeing the skin we can understand that this rukshata is extending to the other dhatus as well, and indirectly contributing to the less vitality of the tissue. So no wonder that if the sneha is less, the tissue vitality is less, then naturally the muscles of the uterus, they are not going to be able to hold that baby, and they are going to result in the preterm labor. The lack of bal of the muscles, मांस धातु का बल become होने वाला है. And again the amniotic membrane, how is it composed? It is composed of the proteins, and this lack of sneha is going to reduce the elasticity, making it more friable. Rukshata, kharata in those amniotic membrane is going to make it more friable and susceptible to the getting torn at an early time in the pregnancy. So this rukshata, lack of sneha, lack of bala, this is going to compromise the overall well-being of the mother and the fetus, causing the other complications that we have seen, the growth retardation, the preterm, going into the preterm labor, premature rupture of membranes, low birth weight of the baby. They are all the reflections of the bala and sneha kshay that are occurring in the mother because of the Pandu. Rajanti kshayam atyartham dosha dushya pradushanat ani sa alpa rakta alpa medasko nissara shithilendriya. So the indriyas are also becoming shithila. Shaithilya, indriya shaithilya can be understood by the looking at the tone of the muscles of the patient. So the complicated labor or the uterine atony, which is also known to occur in anemic patient, is a reflection of the shaithilya of the dhatus. The lack of tone, rakta is the main, rasa and rakta, they are the main precursor of the mansa dhatu, and the bal of the mansa is going to come from the rasa rakta. So this pandu in turn is going to cause the shaithilya of these dhatus, or the muscles of the uterus, which are the main which have to do a lot of hard work during the 10 to 12 hours in the primary or 6 hours in the multipara to push out that baby. So not only is the oxygen compromised, but the bulk of the uterus is also compromised, causing the um, dystocia or the abnormal labor to occur in these women. Garbhini Samanya Chikitsa Sutra, like I said before, whenever we are treating the Garbhini, always we have to remember, consider the Garbha and consider that whatever your drugs and food and medication you are giving are not overly Ushna, Tikshna and Daruna. So सौम्य शीतवीर्य प्राय द्रव्य ही हमें गर्भिणी में यूज करने हैं एंड इसे हमें प्रिवेंट करने के लिए, गर्भिणी पांडु को प्रिवेंट करने के लिए हमें क्या करना है, तो आयुर्वेद के हिसाब से हम उन्हें start catch them when they are young. Start by giving them the proper, advising them upon the proper Rajaswala Paricharya. Nowadays, interest is being generated through the talks of many of my colleagues who are speaking in favor of Rajaswala Paricharya, and so many studies are also coming up which are proving that the seclusion of the woman during the Rajaswala Paricharya contributes to improving her overall health and her reproductive health. We as Ayurvedic physicians need to counsel the young girls or the mothers who of the young girls who are coming to us as patients that at least as far as possible try to follow this Rajaswala Paricharya and not exert during those times, and give due consideration to the Agni and the Bala of that girl while planning her lifestyle during those 3 days at least. So in the long run, if they are going to, we can convince them that following this for 3 days is going to relieve them of pain and problems in the long run, then we will have done our job as Ayurvedic physicians in convincing the society about the need for these paricharyas. Then convincing and counseling them about the proper diet. We are talking about iron rich diet, but at the same time we also need to talk about the chaturvidha and shadrasatmak diet. Excess, both extremes we are getting to see in these girls. Some are the undernourished type of girls who need specifically this balya and madhur ras and this balya ahar, and on the other side we are also seeing girls who are from the, maybe not, it is not just that the these we feel that the junk and these kind of foods are available mostly in the urban areas, but while conducting camps and while seeing the patients from the this rural areas also, I see so many girls are, because of their exposure to, they may not be getting Zomato and they may not be getting pizzas and burgers, but they are definitely having access to these kurkures and chips and vada pav and all these things. So their rural kind of junk diet, it may be a different variety, but it exists. So counseling the whichever class of society these girls may be coming to us, we need to look into what diet they are taking and counsel them about the Shadvidha diet, about the need to be physically active. Because of this COVID, it has given the phone and tapped into the hands of young children, making them totally dependent upon these gadgets for their entertainment of their time pass. So instead of having any meaningful social interactions, having real physical activity, they are logged on to their tabs and gadgets, and that is making them more sedentary. So overall, improving the condition of these adolescent girls by counseling them about these two factors is very, very important, and it can contribute to improving their status in their later lives. Abnormal bleeding issues are also present in so many girls. It makes in the day in the till the hypothalamus pituitary axis, it it matures and starts behaving in a normal way, many girls, they present to us with this excessive bleeding, and they also need to be addressed, and the issues need to be resolved by using medication. Deworming by regularly is also another important point which we should look into before at the baseline only we should take this into account, and uh, treat that point also adequately. Look out for these signs and symptoms of the, if they are having about the worms, treat them, and advise them regarding the use of proper diet, proper medicines for reducing this, even reducing the incidence of the worms, which can be the cause of the anemia in their future life. Then Pandurog Pathya Ahara, lot is being talked about diet, and I want to focus here that the vast variety of foods that Ayurveda has advised for this मुदग आढकी मसूराणाम युष जांगलजा रसाः पटोल वृद्ध कुष्मांड तरुणम कदलीफलम. All these are the fruits which are easily available, things that are easily available and can be advised as Ayurvedic physicians to these women. Jivanti ikshurasa, ikshu matsyakshi, guduchi, tanduliyaka, punarnava. These tanduliyaka, punarnava, they can be advised as vegetables. Like green vegetables are, leafy vegetables are advised by the modern medicine also. But when we think of green leafy, we always think of spinach, and we think of methi, and these commonly found leafy vegetables. But we can also advise them about the punarnava, which can be the ran bhajis. There is a separate lot of information we now get regarding the ran bhajis also. So people living in the rural areas, they are already consuming this, but slowly, because of the advent of the modernization or westernization, if they are losing touch with their culture, we need to, as Vaidyas, we need to get in touch with the this aspect of the, the local culture and local vegetables that are available, and sensitize them and make them aware of the wealth of vegetables that are available at our in our own surroundings, especially in the rural areas, and make them include those, revive that culture once again, and make the people aware about it. Pakwa Amra, Abhaya, Bimbi, Shrungi, Matsyo, Gavanjalam, Dhatri, Takram, Ghrutam, Tailam, Sauviraka, Tushodaka, Navanita, Gandhasara, Haridra, Nagakeshar. Now, so many of these things, they are easily available. Amalaki is like a panacea for all the problems related with Jara and all the women's problem. We can, so many things are there which Amalaki alone, it is useful and easily it is available. So we need to sensitize and make them use this Amalaki in their day-to-day life, not just in the season, but using that Amalaki churna in their vegetable and cooking, and as maybe as a daily teaspoon full of Amalaki that we can advise them. So यवक्षारो लोह भस्म कषायणी च कुंकुमम दाहश्चरणयो संधौ नाभेश्च द्वयांगुलधा. Now this is the general treatment. Of course, we are not going to advise the garbhini for the dahan karma or the kshara karma also. Okay, but we can advise all the other things that have been given here as the pathya by the Bhaishajya Ratnavali. What I came across, I was trying to search for the references, and interestingly, I found a few references that Lason has been advised by our acharyas for as a pathya for the Pandu. And it is interesting to note that I found some studies that garlic, it helps the accelerates the RBC turnover by stimulating the spleen to improve the erythropoiesis. Okay, so somewhere or the other, the drugs mentioned by our acharyas, they function at different levels. The only thing why we are ignoring them is because nothing is coming to light in terms of in the modern parlance. But we need to understand that slowly and steadily, many of the things said in our granthas are being proven by the modern methods of science also. So it helps to enhance the erythropoiesis, and it also because of its sulfur compounds, it increases the ferroporotin also, which we earlier saw. It helps to carry the iron across the cell membranes. So all these somewhere at some point in the chain of hemoglobin preparation, this garlic at multiple points it is functioning and helping to improve the anemia. Another thing, kadali phala also, the masura, mudga, masura was mentioned as the patya. So even these mudga and masura, mudga provides almost 80% of the folic acid daily requirement, and wheat gives us 3 to 4 milligrams of iron per 100 grams. So this is a rich source of iron which we should not ignore, and we should also tell these patients to uh, stress upon the healthy lifestyle. And then masura dal also is providing the good amount of protein, also is given by the masura dal, which is essential for forming these globin proteins. Then the amalaki, the wonder drug of Ayurveda, rich in vitamin C, and also we know all the Ayurvedic aspect of the amalaki, that uh, how it is helpful and what rasayan karmas it is doing. It is one of the very well known rasayana drugs of Ayurveda and most advertised and most globally accepted. And it is interesting to note that vitamin C of the amalaki is heat stable, and plays an important role in the synthesis of the hemoglobin. Then mango, amraphala also has been expressed as the pathya in this thing, and it also contains a lot of vitamin C apart from the other nutrients also. Kadali phala, kadali iron level of the bananas is adequate for persons suffering for anemia. This is the research that I found regarding the anemia, and they are readily absorbed. The iron in the bananas is readily absorbed. It is the Sendriya kind of iron. It is more readily absorbed. And they also contain the B12 and folic acid, which can also be the deficiency, may also be contributing to creating of the anemia. So coming to the drug part of it, what as Ayurvedic physicians, when we come to the when we are talking about this anemia, we need to look at the base also and think about the agni and the gunas that are present in the patient, and the three doshas. So depending upon that, some drugs, depending upon the doshic predominance, we can choose the different drugs, or you can use the same drug with different anupanas and make it work for your patient. Now, Punarnama Mandur is a well-known drug which contains this, the contents you can see on the screen, and a lot of them are working upon the Agni. So all our drugs, many of our drugs, the combinations that are made, they cater to the Agni. And what is the Agni doing is that it is making the drug more biologically available. Bioavailability of the drug is increasing because of these other things, other combinations, other drugs in the combination, which are included in that combination. Then Dhatri Loho is also another drug which is advocated in Ayurveda, and which is a combination of simple Yashti Madhu and Guduchi Bhavana are given to that. Loho Bhasma and Dhatri is used in that. There is one study which was conducted on 35 subjects with the use of Dadimadhikrut and pregnant patient. This is a specific pregnant study conducted in pregnancy anemia. 10 ml was administered orally for 30 days, and you can see the difference in the hemoglobin percent. So 15% of the 15 women of the 35 had 1 gram raise in 30 days, and up to 1.5 grams was raised in 10 women, and in 5 women out of the 35 it was up to more than 2 gram percent was increased in the 3% or 3 women of the 35 women. There must be some so these kind of studies, they tell us the importance of the element of sneha also, because the sneha in the intestines, it is going to help the uh, absorption and bioavailability of that iron or heme molecule, making it more easily available to the mechanism that makes the hemoglobin, making it more readily available to the tissues, making it more easily perfusible into the place where it is the iron is needed. Another clinical study on Garbhini Pandu was, which I have cited here, was so Dadimati Ghruth only. It is the, I think it's the same study. The conclusion I just want to highlight, it was helpful to increase the HB as well as in reducing Pandutva. The subjective symptoms like Pandutva, Pindikodveshtan, Rutspanda, Akshikuta Shotha and Klama were also reduced by the use of this Ghruta. It improved the Agni and the nourishment without any side effects to the fetus and the pregnant woman. Now, conducting studies on pregnant women again is a risky thing because of the regulations that come into play because by the ICMR. So few studies I have found, I am trying to project them over here. This is a comparative study between on Garbhini Pandu of Punarnava Mandur and Dhatri Loha, wherein it was observed that the I'll just give you the conclusions that Punarnava Mandur was seen to be more beneficial in this study than the Dhatri Loha, and we can see that Punarnava itself, apart from being anuloman and mutral, is hepatoprotective and antioxidant. Mandura Bhasma is, of course, it is hematinic, but apart from that, it is cytoprotective and hepatoprotective also. So, seeing the big part that liver plays in the hemopoiesis and in the iron metabolism, these properties of hepatoprotective properties of our drugs are definitely important. Triphala, as we all know, is antioxidant Rochana Deepan Anulomana, but it is also has a role in the absorption and the motility of the digestive materials in the gut. It is a rich source of iron and vitamin C. And Trika 2 is which is also there in this is the bioavailability enhancer. Gomutra, interestingly, I found that it is known for its antimicrobial and antioxidant properties, but it is also anti-anemic due to its erythropoietin stimulating factor. Now, we never dreamed that this how can Gomutra be promoting the useful in the Pandu. So this Gomutra, it is helping by stimulating the causing the stimuluses of the erythropoiesis. That factor is there in Gomutra. So various things are coming into the front. If we just look for it on the Google Scholar, so many things that justify and that validate our acharya, the concepts and medicines told by our acharyas come to the front when we look for it. Buttermilk again is the presence of the probiotics is there, and obviously it promotes the absorption of the nutrients into by the gut, and malabsorption also, which is one of the causes for the anemia, that can be covered by use of the probiotics. Then the clinical case study, another study done on the Draksha Ghruta, it showed that subjective parameters and objective parameters both were favorably it was favorably recovered by the use of the Draksha Ghruta. Another study, it is the Ayoraja Ayoraja Vyoshadi Vidanga Churna. A case study is there. This case study, in this case study, this Ayoraja, this combination Vyoshadi Vidanga was used in the Panduroga, in the Panduroga, and in this Garbhini Pandu, and 6 grams was given in 2 divided doses per day, and with Madhusarpi. Now the Anupan also makes a difference. Madhusarpi, the Yoga Vahitva of this combination is going to definitely help and improve the absorption and the hemopoiesis. So this was given, and the patient's HB, it has risen point from 8.4 to 10.6 in the period of 3 months. So these are a few studies which I have found regarding the Garbhini Pandu on the net, and I have to try to bring them forward. Of course, Pandu, general Pandu Rog, almost everybody must be treating in their clinics, and the same drugs we need to use with Yukti in the Garbhini, considering the Agni, considering the gunas, Rokshata, Snigdhata, and the Doshik composition, the Prakriti of the patient. Same drugs can be used by keeping the principles of treatment for the pregnancy in the mind, of not to use the Ushna Tikshna drugs. And systemic review, this Sarva Jwara Hara Loha, it was found to be Punarnavadi Mandur. It was also used in this study, and most of this, it is conclusion of this study was that most of these drugs are found effective in the iron deficiency anemia. I have given this links also here, and so anybody who wants to go into the details for this study can search them on the net. They are freely available. To go into the, if you want to go into the details of all this. So our government has made this strategy that Anemia Mukta Bharat should be done, so that the adolescents and women in the reproductive age between the year 2018 and 22, it should be achieved. This target was given by our government to make, and for that, they are the strategy they have taken out is that the prophylactic iron folic acid supplement, deworming, and testing of the anemia, year-round campaigning, and managing the pregnancy and this labor in a proper manner. All these are the mandatory things, mandatory provision of iron, folic acid, fortified food, and addressing the non-nutritional causes of anemia in endemic pockets, with focus on malaria. Certain areas are known to be have hemoglobinopathies like sickle cell, uh, and then the fluorosis. So area where the fluorosis is endemic, such areas they have to concentrate. So this is the target given by the government, and they are working towards it. So as we can align our goals with the national goals, and make a contribution to free the make the life much safer for the pregnant woman in India. With this, I would like to conclude, and thank you for the opportunity, and thank you for all for a very patient listening.
Thank you very much, ma'am, for such detailed, knowledgeable lecture. If anybody is having queries, they can ask directly, ma'am, or type in chat box.
So contact number she has told me to share. I will. Okay.
Yes, I will share in group.
Okay. Yeah.
Okay.
I'll just put it on the screen.
Yes.
It is actually a vast topic. We have talked only about the iron deficiency, but that covers mostly 95% of the anemic in pregnancy. There are other anemias also to consider, like the folic acid deficiency, B12 deficiency, which we have not taken up just now. But major part is related to the iron deficiency, which I have tried to cover.
Okay, thank you, madam.
Okay.
की अनुमति हो तो इस सेशन हम यहाँ पे कंक्लूड करते हैं.
Okay. Thank you so much.
Thank you very much. पुनर्मिलामः. धन्यवादः.
And thank you for giving me this opportunity, Mahesh ji and Sarika ji. I'm very grateful for that. Thank you so much.